This is the part 2 video of the complete hemodialysis series. For those who didn't complete the first part, see the previous video and come to this because this is a continuation of the previous one. So in the first video regarding the hemodialysis summary, we have seen the 4 important components of hemodialysis apparatus. Those are blood circuit, hemodialysis machine, dialyzer and the dialysate circuit. These are the 4 important components. Today we will see regarding the one of the component of blood circuit, which is vascular access. Vascular access, what is it? Suppose if we have to start a dialysis for a particular patient, the blood will be taken from the patient to the machine and returned back to the patient. So to take the blood from the patient to the machine, what we need is the vascular access. The dialysis can be started for either of the two reasons. Either it can be a acute kidney injury, that means the kidney failed in a short period of time and there is a chance of recovery, that means the dialysis might be stopped in the future. Second one is the chronic kidney failure or the chronic kidney disease, where the patient reached the end stage, which is called as ESRD, end stage renal disease. The patient required dialysis for a long period of time because there is less chances of recovery. So the vascular access for acute dialysis and chronic dialysis can be different. Today we will see regarding the chronic dialysis, the best vascular access for chronic dialysis, which is also called the lifeline for CKD patient, is atriovenous fistula. So regarding the introduction of this atriovenous fistula, we will see back some history. In the beginning, when they have realized kidney function can be replaced by the process called dialysis, they have came up with, the scientists and the doctors, whoever, they have came up with the dialyzer. Okay, dialysis is started. There is no problem. The dialysis started for the kidney failure patient. Once we take the dialysis for CKD patient or the chronic kidney failure patient, they need the dialysis for the long period of time, over years, over months, more than that. So how to take the blood from the patient to the machine over a long period? What is the problem? See, what is the problem in that is patient and the machine or the dialyzer, whatever is it, because in the beginning the machines were of different dimensions. Just let us take the current machine. The blood have to come from the patient to the dialyzer at a particular speed, or the blood have to be pumped out. For that we have to prick the artery. But if we prick the artery, take once or twice is fine, but over a period of time artery will be damaged. We can't cannulate it at a multiple times. What else to do? We can cannulate the vein or try to take the blood from the vein as we do it for sampling, but that won't work because venous blood won't come at a particular force. It will be stagnant. Yes, you put a suction pressure, blood will come, but if the suction pressure is not there, the blood won't come. And the speed at which the venous blood can be sucked out in the artificial circuit is also limited. You can't take a blood at example at 150 ml per minute or 200 ml per minute. You can't do that because the vein won't be having that much fast supply of blood. So these are all the two important problems. See, this is the machine. The blood have to come from the patient and go back to the patient. Even if we take at the current days, where we will take the blood from? So this is the major problem in the beginning. The vascular access, the long term dialysis. The main important problem is the vascular access. How to take the blood from the patient to the machine and return it. Because after repeated cannulation, the artery will get damaged. Even the vein might get thrombosed. So the scientist or the doctors over a period of years they came up with multiple options like breaking the artery and connecting it to the tube and returning the blood to the vessel, that is the vein. That was one option. But the problem was the tube used to get thrombosed. So then also there was a failure. So what they have found, this is the forearm and the hand, the radial artery, ulnar artery. These are all the veins, the prominent veins. How to make it as a vascular access? So they came up with initial ideas. The Scribner in 1960s, he tried a artificial shunt, which is called the Scribner shunt. Some kind of artificial tube is taken, connected from a particular artery to a vein where it goes in the circulation. So this delivers the high flow of blood to the artificial circuit and it can be kept in situ for a particular time. This is Scribner shunt. This is how it appears. In nephrology quiz, they might keep this image and ask you what is it. This is Scribner shunt. Since it is a artificial shunt, the chances of infection and the chances of thrombosis, there is a difficulty in placing this. These are the problems which were encountered. But it served the purpose. What is the purpose? It served blood to the dialyzer at a particular speed. The flow was not limited. The repeated cannulation and arterial damage can be minimized. Then came the arteriovenous fistula. It is nothing but AVF, which is arteriovenous fistula. What is it? It is just a connection between the artery and the vein. What is the advantage? It is autologous, no foreign body is involved, so there is less chance of infection. Second, it serves the purpose of delivering high blood flow into the vein. Third, the vein can be cannulated multiple times because there is a remodeling of the vein walls. Why? Because of the increased flow from the artery. So it served the three purpose. So that is how this arteriovenous fistula have been started using for dialysis, especially for long-term dialysis. This is not for acute condition, it is for long-term dialysis. So this is also called as lifeline of CKD patient. So in 1965, the scientist, the doctor have created the first autologous fistula which served all the purpose. It was being named as the Brecicossemino fistula. You might have seen in Harrison also, or any beginner dialysis technologist book, or in the Washington Manual of Medicine. Sorry, manual, uh, dialysis manual, the handbook, the Ugrida's handbook. You can see this is what it is mentioned. So this is how it is. This is the artery being connected to the vein. So this is called as radiocephalic fistula. Today is the introduction for the fistula, so that is why I am just showing where the fistula was made in the initial times. The radial artery being connected to the cephalic vein. The cephalic vein will undergo remodulation, so there will be a high flow of blood in the vein which can be cannulated multiple times. So this is AV fistula, which is a subcutaneous anastomosis. Usually non-dominant hand is being selected, which is the mainstay of vascular access for the CKD end-stage renal disease patient. So today we have seen regarding the radiocephalic fistula connection. It can be made in the elbow region also, which is called as brachiocephalic fistula. Brachial artery, cephalic vein and the fistula. Radial artery, cephalic vein and the fistula. One more terminology comes. How the connection is being made. For example, this is the artery, radial artery. This is the vein. If these two sides are connected, this is called as side to side connection based on the type of connection. What is the second one? This usually we won't use. This is called as end to end. Both the radial artery, the cephalic vein is connected and the other end is being cut and tied. The blood supply to the hand will be compromised in this, so we won't use this. Is end to end. So this is depends on the vessel, one classification, and you have to know which method is being used. Third one, this is side to side, sorry, end to side. This is the artery, one side is being connected, vein, end of the vein is being connected. This is called as end to side. Commonly side to side and end to side is being used. The question arises, sir, if end to side, for example, end of the cephalic vein is connected to the artery. In the beginning, many DM first year residents or the MCS surgery who handles fistula, they have a doubt that the cephalic vein have been completely tied at the distal end. Thus, the hand will be swollen up. No, there will be a lot of tributaries which takes down the venous blood into the other tributaries. So there won't be any much swelling. So these are all the three type of connection. Commonly we use side to side and the end to side. This the we usually won't use. So this is another image regarding the radiocephalic fistula. Side to side connection is made. After a period of time, this vein became remodeled with a lot of blood supply. Two cannula can be put, one to take to the dialysis machine. From the other, the blood can be returned back to the patient and the flow will be good because the blood is being supplied by the artery. The vein walls go for remodeling, so repeated cannulation there won't be any issue. It is not a foreign body, it is autologous, so all the advantages of the demerits which have been encountered in the initial times have been sorted out with this AV fistula. So this is regarding the introduction of the AV fistula. What is the summary? It is one of the vascular access modality used for the chronic kidney failure patient, also called as lifeline for CKD patient. Third, why lifeline? Because end-stage renal disease patient, they can't survive without dialysis or transplant. Dialysis can be done with the help of fistula only. Third, it is an autologous one, most commonly used in the forearm region. So this is the summary of this video. The next part on AV fistula will be uploaded soon. So to be continued. Bye bye.